So, hello friends, our today's topic is about the megaloblastic anemia. So, what do you understand by megaloblastic anemia? We know megaloblastic anemia, they are the group of disorders that are characterized by impaired DNA synthesis, primarily it occurs due to the deficiency in the vitamin B12, that is cobalamin, or the folic acid deficiency, that is the folate deficiency. So these deficiency they lead to development of anemia. And what you see here is the presence of enlarged red blood cells. So these enlarged red blood cells they are also known as macroovelocytes, having mean corpuscular volume greater than 100 femtoliters. So in the bone marrow, you will see there would be increase in the red blood cells production, that is erythroid hyperplasia, along with the megaloblastic changes. The megaloblast it is distinctive abnormal cell that is seen in these conditions that results from the hindered formation of DNA caused by deficiency in vitamin B12 or the folic acid. We know vitamin B12 and folic acid they are important for the DNA biosynthesis. Changes can be observed in various tissues like the buccal mucosa, tongue, small intestine, cervix, vagina, as well as the uterus. So what are the consequences? You can see apoptosis, the abnormal cells might undergo programmed death due to the mismatch between nuclear and cytoplasmic maturation. Second is the ineffective erythropoiesis. So the disrupted maturation process, it would lead to production of immature RBC. So these RBC, these immature RBC, they are incapable of functioning properly. That would lead to ineffective blood cell production. So these abnormal red blood cells, they will rupture prematurely within the bone marrow. That leads to destruction of red blood cells before they fully mature. The abnormal maturation affect not only the red blood cells but also other blood cells that results in a low level of white blood cells as well as the platelets. So the disruption in DNA synthesis caused by deficiency in the vitamin B12 or the folic acid it leads to significant abnormalities in the cell maturation as well as their. Now what are the causes through which this cobalamin deficiency arises? The first of all is the nutritional deficiency. Inadequate consumption of food that are rich in vitamin B12. It is particularly notable in strict vegetarian who have a strict vegetarian diet who exclude animal based products from their diet. They are the primary source of vitamin B12. Second is malabsorption. Issues related to absorption of cobalamin from the food can lead to deficiency. So reduced stomach acid level can hinder the release of vitamin B12 from food. Surgical removal of portion of stomach, it can also affect the absorption of vitamin B12. Drug those blocking the gastric acid secretion. The medication, they can interfere with the stomach acid production and hence they can affect the cobalamin absorption. The third is inadequate production of intrinsic factor. We know that intrinsic factor it is necessary for the absorption of the vitamin B12, right? So condition that impact its production or function is the when you remove the surgical when there is surgical removal of entire stomach that eliminates the production of the intrinsic factor. Diseases like tropical sprue, celiac sprue, they can affect the absorption of vitamin B12 as the ileum is crucial for B12 absorption. We know that. Third is the granulomatous diseases that can interfere with the B12 absorption. Some drugs they can also interfere with the vitamin B12 absorption. The drugs can be colchicine, neomycin. They can affect the vitamin B12 absorption. What are the uncommon causes of vitamin B12 deficiency? They could be pernicious anemia. This it is an autoimmune condition that involves the distinction of that involves the destruction of the parietal cells in the stomach. So when there is destruction of parietal cells, that results in decreased production of intrinsic factor, and without intrinsic factor, vitamin B12 absorption would be impaired, and hence that would cause a deficiency. Sometimes there is congenital absence or functional abnormality of this intrinsic factor that may also cause vitamin B12 deficiency. Crohn disease, the inflammatory bowel disease, can affect the terminal ileum, impairing the absorption of vitamin B12 that normally occur in this part of intestine. Infection by particular tapeworm, it can cause vitamin B12 deficiency as the worm competes with the host for absorption of this vitamin in the gut. Transcobalamin 2, it's a protein that helps to transport vitamin B12 in the blood. A deficiency in this protein can hinder. Now, what are the causes of folic acid deficiency? Nutritional deficiency, inadequate intake of food that are rich in folic acid is the primary cause. Diets that lack green leafy vegetables, fruits, cereals, they are common source of folate that contributes to this deficiency. Increased requirement, certain life stages, they need certain conditions like infancy children. Due to their rapid growth and development, they require increased folate. Pregnancy, the demand for folate rises during the pregnancy to support the fetal growth. Some cancers or tumor can also lead to folate, increased utilization of folate causing its deficiency. Apart from that, chronic hemolytic anemia, when there is a breakdown of RBC, that can lead to increased demand for folate, that can also result in deficiency. Skin conditions, when there is excessive shedding of skin cells, that may increase the body requirement for folate. Some individual undergoing long-term hemodialysis may experience folate deficiency. This occurs due to increased loss of folate during the process. There are some drugs or medications that can interfere with the folate level, like the phenytoin, barbiturates. They interfere with the folate metabolism. Impaired metabolism, some medication act as an inhibitor of dihydrofolate reductase. So that is enzyme that is involved in folate metabolism. So these drugs, like the methotrexate, they are used in certain medical conditions. They will inhibit the folate metabolism and hence can lead to deficiency. Alcohol consumption, when someone drink excessive alcohol, it can interfere with the folate absorption and hence leading to the deficiency. So identifying the cause of folic acid deficiency, it is important for proper management and supplementation, especially concerning neural tube defects in newborns. Now, what are the rare causes that leads to folic acid defect deficiencies? Like the rare enzyme defect like dihydrofolate reductase. So that is involved in folate metabolism, that can also lead to folic acid deficiency. Drug that impair the DNA synthesis, like the purine antagonist, pyridamine antagonist, they can also interact with the folate metabolism. Disorders, metabolic disorders like Lesch-Nyhan syndrome, hereditary orotic aciduria, so they all can cause, then can lead to folate deficiency. Now, the prevalence of megaloblastic anemia, it varies. Number one, we know that dietary and pregnancy related folate deficiency, they are the common cause of the megaloblastic anemia. Inadequate intake of folate rich food can lead to this deficiency. Second, pernicious anemia. We know it's an autoimmune condition that leads to vitamin B12 deficiency. Again, it occurs due to the impaired production of intrinsic factor. So pernicious anemia, remember, it is more commonly observed in the older individual. Other is the cobalamin deficiency that arises from the inadequate intake of the animal products, which serve as the main dietary source for the vitamin B12. What is the minimum daily requirement of vitamin B12? Now, what are the clinical manifestations of cobalamin deficiency? You can see premature graying hairs, mental sluggishness, atrophic glossitis, that is shiny tongue, and broad shuffling gait. So glossitis, you will see inflammation and soreness of the tongue, that is atrophic glossitis. Thinning and inflammation of vaginal walls, that is vaginal atrophy. Difficult absorbing nutrients for the digestive tract, that is malabsorption. Increased pigmentation, that is hyperpigmentation. Symptoms like tingling sensation, paresthesia, numbness, weakness, impaired memory, and physical changes, personality changes due to the neurological impact, that is neuropsychiatric problems. Apart from that, you can see anemia, macrocytic anemia, megaloblastic anemia. There might be thrombocytopenia, low platelet count, and neutropenia that leads to overall pancytopenia, that is the hematological abnormalities. So you can see neurological abnormalities. There may be degeneration, a distinctive lesion that affect the specific part of the spinal cord. So these conditions specific to vitamin B12, it is characterized by a defect in the myelin formation that covers the nerve fibers and sports proper signals. So progression of symptoms begins with sensation like tingling, numbness, and there may be difficulty in coordination, that is ataxia. So in severe cases, the neurological symptoms may progress, and one can see people with severe weakness, muscle stiffness, that is spasticity, involuntary muscle contractions, that is clonus, paralysis of the lower limb, that is paraplegia, and loss of the bowel and the bladder control, that is fecal and urinary incontinence. So the neurological abnormalities that are linked to vitamin B12 deficiency is the number one, there is axonal degeneration of the peripheral nerves, the central nervous system symptoms, memory loss, irritability, dementia that could be seen. Now the folic acid, we know it's an important nutrient that is found in animal products and the leafy vegetable, typically in the form of polyglutamate. Normally, daily requirement for individual not under stress condition, its normal value is 200 to 400 microgram per day. But in the pregnancy, this demand will increase from 200, 400 to 500 to 800 during the pregnancy or lactation due to greater demand for the fetal development as well as the milk production. So the primary cause of this folate deficiency is the nutritional from the poor dietary intake or alcoholism. Apart from that, the cooking can easily reduce its availability. The folate, it enters the cell by binding to receptor, that is folate receptor, and once it is inside, it is transformed into active form, that is polyglutamate form. So this active form, it cannot diffuse back into plasma. So the cause of this folate deficiency include, number one is the alcohol consumption. It can decrease the serum folate level by impairing the absorption. Pregnancy, patient with hemolytic anemia, skin disease or certain drug induced interference with the folate metabolism, they can elevate the folate demands. Some drugs like trimethoprim or the methotrexate, they can interfere with the folate metabolism that can lead to its deficiency. Now the diagnosis of the megaloblastic anemia. What are the key steps? The first is elevation in MCV, that is red blood cell mean corpuscular volume. It is the hallmark feature of the both cobalamin and folate deficiency. The second, peripheral blood smear examination. So this test, it helps to visualize the morphology of the blood cells under microscope. It can reveal, you can see if the macrovalocytes. What are those? They are the larger the cells that are larger than the normal red blood cells that are occasionally megaloblast. Apart from that, you will see hypersegmented neutrophils. the neutrophils with more than usual number of lobes. So even 5 or more lobes, that the hypersegmentation indicates alteration in the late stage granulopaths. Third, you can measure the level of cobalamin and folate in the blood. It can directly, you can assess their concentration. The low level are indicative of deficiency. Apart from that, evaluation of methylmalonate and homocysteine level in the blood can also help to confirm the cyanocobalamin deficiency. Other tests are the evaluation of serum bilirubin and lactate dehydrogenase. So that can reflect the increased red cell breakdown. So that would be the cause would be ineffective erythropoiesis. Apart from that, you can do is bone marrow aspiration and biopsy. They are the further diagnostic procedure. So you will see hypercellular marrow with the megaloblastic erythroid hyperplasia. That means there would be increased blood cells precursor showing megaloblastic changes. Apart from that, you can see giant metamyelocytes. These are the abnormally large immature WB. So when the cobalamin levels, remember, they are more than 300 picogram per milliliter, so that is normal. But when the levels are 200 to 300 picogram per milliliter, that's the borderline, and less than 200 picogram per milliliter, it is considered low and cobalamin deficiency. Whereas the serum folate concentration, it is more than 4 nanogram per ml, it effectively rule out folate deficiency. So the red cell folate concentration, it is a more reliable indicator of tissue folate, since it will reflect a time average value of the folate availability. So suppose if the cobalamin and folate level, they are equivocal. So in case, the next step you would evaluate is methylmalonic acid and the total homocysteine. So analyzing the serum concentration of these metabolites, this will help to diagnose when the cobalamin and folate alone do not provide a clear indication. The elevated level of methylmalonic acid and homocysteine, it can indicate the metabolic disturbances that are related to cobalamin. So on peripheral blood smear, first of all, you would see macrovalocytes. They are the larger than the normal red blood cells with the oval shape, which are indicative of abnormal red blood cells. Apart from that, you can see hypersegmented neutrophils, neutrophils with more than usual number of lobes in the nucleus, typically 5 or more lobes. Apart from that, you can see scanty platelets. So unlike the cobalamin deficiency, in the folate deficiency, homocysteine level, they are elevated, as folate does not participate in methylmalonic acid metabolism. In case of cobalamin deficiency, there is decreased rate of metabolism leading to elevated serum concentration of both methylmalonic acid and homocysteine. So elevated level of methylmalonic acid and homocysteine, they are potentially indicative of cobalamin deficiency. Other test that you can use is the anti-intrinsic factor antibodies or Schilling test. The Schilling test, it is less commonly utilized nowadays due to the alternative diagnostic methods. Now, what would be the treatment of cobalamin deficiency, especially in the pernicious anemia involving the vitamin B12? First of all, you can give is the parenteral cobalamin therapy. Initially, intramuscular administration of 1000 microgram of cobalamin that you can give every day for 1 week. Following the initial phase, the treatment, it continues with 1 milligram of cobalamin every week for 4 weeks. That is, if the underlying conditions such as pernicious anemia, it persists, the patient may receive 1 milligram of cobalamin every month for rest of their. Apart from that, you can give is oral cobalamin formulation. The oral dose, it ranges from 1 to 2 milligram per day. So what are the indicators of treatment success? What are the indicators of the success of the treatment? First of all, in patient with severe anemia, serum iron level decreases within 24 hours of initiating therapy. So the serum lactate dehydrogenase levels start to decline within 2 days. The hypersegmented neutrophils, they disappear within 10 to 14 days after the start of the treatment. What are the treatment for the folate deficiency? The folic acid therapy, the dosage orally required is 1 to 5 milligram per day, and duration is from 1 to 4 months. Typically 1 milligram is sufficient even in the presence of malabsorption issues. So remember, it is important to exclude the cobalamin deficiency before initiating folic acid treatment for the megaloblastic anemia. If the urgent treatment is necessary, both folic acid and vitamin B12 should be administered simultaneously until test result confirm the diagnosis.